Hi everyone, I'm Dr. Somya Jain. I'm a practicing rheumatologist. I'm MD in medicine and I did my fellowship in rheumatology from the prestigious Sir Gangaram Hospital, New Delhi. Today I am here with a renowned cardiologist from Medanta, Dr. Nagendra Singh Chouhan. He's a senior director, he's interventional cardiologist there. So we'll have a chit chat with him regarding some inflammatory disease and prevalence of heart attacks and more increasing in prevalence in cases like rheumatoid arthritis and lupus. Sir, welcome you.
Thank you.
So sir, what are the different aspects that you are noticing in the inflammatory disorders? Like most commonly we are having rheumatoid arthritis. The prevalence of rheumatoid arthritis is 1% overall, and it's increasing day by day, and the main cause of mortality and morbidity is cardiovascular diseases. And I am a great follower of Dr. Anand Mohan Malviya and have heard lot of lectures of him, and now there is a dictum to place a statin in every patient of rheumatoid arthritis and lupus.
The problem, I think, is the atherosclerosis. This is an inflammatory disease. Although previously you were thinking that there are multiple other issues, now there are many signs which are saying this is an inflammatory disease. And we have seen in many patients, so now it's considered a dictum that for all patients of our heart disease also, even if there is no rheumatoid arthritis, we are doing in a CRP level, especially the high sensitive CRP levels. And recent data has shown a causal effect also, that if we use colchicine, which is anti-inflammatory drug, then it can prevent heart attack in patients with high risk and diffuse atherosclerosis. So in many patients we are using this also. So we have to understand that whatever is the disease, ultimate demise generally happens because of either heart disease or kidney disease. Both are quite common in rheumatoid also, and this ultimately is because of inflammation. So if there is inflammation, inflammation means कहीं पे भी सूजन आ गई है, तो जब भी कहीं पे सूजन आ गई है बॉडी के अंदर, तो deposition of cholesterol का चांस बढ़ जाता है. So rheumatoid arthritis again is an inflammatory disease, so there is inflammation of joints and connective tissue disorders are there, but this also affects the blood vessel lining, and there is inflammation in the endothelium. So that endothelium, which is the inner lining of blood vessels, which is supplying blood to the body and to the heart, is a problem. And if there is inflammation, that causes cholesterol deposition, and ultimately cholesterol deposition is not a problem. As I previously discussed also, the heart attack happens because of crack in cholesterol deposition. And जो ये crack आता है is generally happening because of inflammation. What is inflammation? Inflammation is basically the white blood cells in the body, they are entering into the endothelium and they are basically trying to control the infection, but actually it is not infection, it's just inflammation. So it's detrimental to heart, and these causes crack in heart, and that causes heart attack. So now inflammation is considered a major risk factor, and in many patients actually we are treating inflammation also along with heart disease. So Dr. Sahab, you are very right that rheumatoid arthritis or many other inflammatory diseases, we are facing many problems in these patients, and they are ultimately ending up in heart disease. CKD patients are ending up in heart disease because of inflammation. So that is a major concern. So I think it is very important that we should know if we have inflammatory disease, we should have a regular checkup. If we have family history of these kind of diseases, we should be in touch with some rheumatologist to see that what is happening in body. And ultimately, for all diseases, we always say that we have to control our risk factors, which is very important.
In fact, nephrologists in cases of cardiorenal syndrome and this, they are in habit of putting statins first nowadays, with febuxostat and this like that. Uric acid also plays a role in as a anti-inflammatory. So sir, do you have any particular choice of putting any particular statin? We are in habit of writing like there are low intensity statins, there are high intensity statins. Rosuvastatin is considered to be a high intensity statin. So do we choose any particular statin?
So I think data is not that robust in terms of choosing it, but still there are certain indicators. So why? So there was one time when it was thought कि क्यों ना statin को खाने के आटे में मिला दिया जाए और सभी को खिला दिया जाए. So there are multiple reasons कि ये नहीं हो पाया, because although we know disease is there and heart attacks are happening because of this, but population wise if we say that benefit is not that good and there are some risks also. So जब भी हम कोई भी drug देते हैं, there is always some risk involved. So although the risk is not that much, फॉर ए पेशेंट अगर मुझे हार्ट डिजीज़ होने का चांस ज़्यादा है तो मेरे लिए उसको खाने का बेनिफिट बहुत ज़्यादा है, रिस्क बहुत ही कम है. सो जिनको डिजीज़ है या जिनको होने का चांस है उन्हें इस चीज़ से डरने की ज़रूरत नहीं है, लेकिन जिनको डिजीज़ नहीं है अगर उन सबको भी हम देंगे तो वी हैव सीन इन सम पेशेंट्स डायबिटीज़ का रिस्क थोड़ा सा बढ़ा हुआ मिला है हमको। एंड इन सम पेशेंट वी हैव सीन इन किडनी डिजीज पेशेंट्स ऑल्सो वी हैव सीन कि किडनी प्रॉब्लम्स आर स्लाइटली प्रोग्रेसिंग फास्टर if we use high intensity statins. So even in CKD patients now we generally prefer atorvastatin over rosuvastatin. In many patients who are otherwise obese but no other risk factors and they have borderline HbA1c, we prefer atorvastatin. But in all other patients where risk is high, we always prefer high intensity statins because they will give better benefit in terms of outcomes. So generally we prefer high intensity statins for all the patients who are high risk, like a rheumatoid heart disease patient or a CKD patient in which the disease is full blown, or a diabetic patient, we always prefer rosuvastatin over atorvastatin. But there are few subgroups where we even prefer low intensity statins also because the risk is less and we want benefit but we don't want side effects. So that's how we decide which statin is to be chosen. There is one other problem also with the statins, they causes muscle spasm and muscle cramps. So very few people actually are having serious problem, but in those cases sometimes there are some other statins also available like pitavastatin. So with that can also be used, although the benefit of those statins is not that robust as rosuvastatin. So we have to assess how much is the risk and how much is the benefit, and I think a physician or a cardiologist can decide which is best for you. But definitely if you are at high risk, you should not be shy away of him and you should be taking it regularly because benefit weighs much more than the risks.
And how common is the incidence of diabetes with statins?
So in the studies it was found that if you have other risk factors, if you are prone to diabetes, like if you have family history and all, then 1 to 3% of patients can develop diabetes, which is not that much. But in patient, if you have no other risk factors and you are obese, then generally we have to see that is it really required to give statin or not, or at high doses statin or not.
And sir, what about the criteria, like we see that you were just speaking about LDL?
Yeah.
It is only LDL and it's some other part of HDL also, it should be good, and LDL should be less than 100 in a case of pre-diabetic, or like we said.
So basically we have to understand cholesterol is a very broad term. So blood cholesterol level is a very broad term. Cholesterol mein there are multiple parts: LDL, HDL, VLDL, triglyceride. Now we are even discussing about ApoB, LPA. So there are multiple risk factors. What we have found is that LDL is the most important risk factor, which is directly correlated. Then the second thing we call it as non-HDL cholesterol. No. So that is mainly triglyceride and ApoB and other smaller or bigger molecules. So first focus is on LDL. So anything LDL, we say normal level is 100 for general population. If patient is at risk, like if you are diabetic or if you are even pre-diabetic and you have a family history of heart disease, or any kind of, or you are obese or you are a smoker, then you are at risk. So all these patients who are at risk, we say that ideal level should be 70 for them. And all those patients in which disease is already developed or they have multiple risk factors, we say that the LDL should come down to 50. And in younger patient, if the disease is coming very early, especially in Indian population, now we say that it should be below 30. So this is one thing, but definitely other risk factors are also important. So it is difficult to tell that which is more important, but I think right now we should focus on LDL.
What about the use of, when we were doing our MD, we used to use these GP2B3 inhibitors. Are they obsolete nowadays in acute coronary syndromes, or is there a place for them?
So basically there are multiple drugs coming nowadays. So ultimately what we are worried about is platelet or blood clotting particles in the blood. Platelets are a problem for heart attacks, and we are using drugs like aspirin, clopidogrel. So now new drugs are there which are much more potent. So when new drugs are available, then that has that is the reason that the GP2B3 uses have gone down, because GP2B3 are very costly and they have an incidence of bleeding also. And with newer drugs available, and now we are using almost 100%, we are using newer drugs which are much more potent, which are effective within half an hour. So use has significantly gone down, but still in younger patients, when there is lot of thrombus burden, means the blood clot is too much, we still use GP2B3 inhibitors in some selected patients.
So how do you cope up with that? Those type of patients having upper GI bleed, has a recent ACS, has a recent PTCA, is on double antiplatelet drugs, and then we are stuck there.
I think this is a very major problem, and this happens mainly in patients who are having multiple problems, like if he has already gastric ulcer and all, and now he is coming with a heart attack and we are giving it blood thinners. So for initial 1 month we say that double antiplatelet is really important. We should not stop before 1 month, but in selected patients, even at after 1 week, now we are stopping aspirin. So previously aspirin was considered the most important drug. Now we are stopping aspirin and continuing one drug, or the P2 Valter inhibitor like clopidogrel or ticagrelor or prasugrel for next 1 to 3 months. And if patient requires, like has significant bleeding in first 1 month, we say that replenish it with blood, don't stop medicines, and after 1 month you can stop medicines if required.
Okay sir, one last question from my side कि जो ये भी इंसिडेंस इसमें देखा जा रहा है यंग्स में, हम देख रहे हैं जिम गोइंग वर्कर्स में, क्या ये सप्लीमेंट से आप इसको कोरिलेट करते हैं, तो या स्टेरॉइड्स और ये इंडिजिनस मेडिसिन ले रहे हैं, जो देख रहे हैं कि स्टार्स में भी हॉलीवुड में भी जिम कर रहे हैं और फिर ये सडनली क्रैश डाउन हो जाते हैं, कार्डियक अरेस्ट इज द कॉज ऑफ डेथ. तो ये यंग्स के अंदर ये क्या ये स्मोकिंग से ओनली रिलेटेड है, स्ट्रेस फैक्टर्स हैं, तो मतलब मल्टीपल फैक्टर्स?
आई थिंक जो हम आजकल सोशल मीडिया पे काफ़ी कुछ देख रहे हैं उसके अंदर मल्टीपल थिंग्स इन्वॉल्व. वन थिंग इज नाउ बिकॉज इट्स अवेलेबल ऑन सोशल मीडिया, तो हम लोगों को पता ज़्यादा चलता है कि ऐसा हो रहा है. सेकेंड विच इज़ इवन मोर इम्पॉर्टेंट इज दैट हमें नहीं पता है कि हमारा बेसिक कार्डियक स्टेटस क्या है, और सडनली हम एक दिन जिम जाके जिम ज्वाइन करते हैं एंड रन करना शुरू कर देते हैं, एंड बिकॉज अदर पर्सन आर रनिंग, हम लोगों को उनसे कम्पीट करना है तो ओवर हो जाता है. तो बेसिकली आपको एंड्योरेंस नहीं है. हाउ टू अंडरस्टैंड दैट इज योर बॉडी एबल टू सस्टेन दैट और नॉट. आपको कोई रिस्क फैक्टर तो नहीं है, आपको डायबिटीज़ तो नहीं है, आपको पहले से हार्ट प्रॉब्लम तो नहीं है, इज़ योर हार्ट एबल टू टेक दैट लोड और नॉट. तो ये सब समझना बहुत ज़्यादा जरूरी है. ज़्यादातर जो पेशेंट में हो रहा है, दे आर स्मोकर्स, दे आर एल्कोहलिक, दे आर डायबिटिक, they are not doing any activity and suddenly they are joining gym. So exercise, if you don't do it regularly, is a trigger for heart attack. So many patients have heart attack while they are on treadmill. This is because during heart attack, heart is not getting enough blood, and that is happening because of crack in heart blood vessels. Again, exercise is a stress to heart. जब हम तेज दौड़ेंगे तो blood pressure बढ़ेगा, that causes this kind of problem. So दोनों ही reason है कि आपकी बॉडी अकस्टम नहीं है, आप स्मोक कर रहे हैं, प्लस आजकल ये यंगर पॉइंट्स में ये भी देखा गया है दे आर यूजिंग ड्रग्स विच इज डेंजरस, दे आर यूजिंग वेप विच इज ऑल्सो डेंजरस. सो ऑल दीज थिंग्स आर लाइक coming together and causing this problem. So we have to understand that we have to have a basic physical fitness. We should go for a routine checkup before this, and then we should do it.
Thanks a lot, sir.
Thank you.
My queries are being cleared, and it was a very nice interaction with you.
Same here,
We'll
sir.
hope the same again in near future.
Definitely.
Thanks a
Thank
lot,
you.
sir.